Good afternoon, everyone, and welcome. We at St. Paul's Foundation are privileged to be presenting as guests here on the traditional, ancestral, and unceded territories of the Musqueam, Squamish, and Tsleil-Waututh nations. It's been 13 days since the remains of 215 children were confirmed to be buried on the grounds of the former Kamloops Indian Residential School, a truth known by Indigenous people for decades. While we process feelings of sadness and grief, we reflect on our responsibility in addressing the legacy of colonialism and its present-day harms. Providence Healthcare is committed to the process of truth and reconciliation with Indigenous peoples in BC and to embed reconciliation in everything that we do. As a healthcare organization, we are accountable to heal, not harm. We owe this to every child silenced, to their families and future generations, and to all people we serve. Earlier today, at 2:15 p.m., we observed a moment of silence. We reflected as an organization and individually on our commitments to truth, self-education, self-reflection, and reconciliation. We ask and offer you that opportunity, a moment of silence, now. Thank you. My name is Brooke Bosma. I'm the Chief Development Officer at St. Paul's Foundation, and I'm so pleased to have the opportunity to have you today, our generous donors and supporters. I'm going to take you on a behind-the-scenes tour of one of the newest clinics at St. Paul's Hospital, the Rapid Access Chest Pain Clinic. During this virtual tour, you'll get an insider's look at the incredible space on David Street, meet the innovative physicians who are practicing a new and personalized model of cardiac care in BC, and see exactly where your donor dollars have gone to support research, early prevention, and life-saving treatment needed to improve cardiac care. You'll also get a glimpse of our donor-funded cardiac CT scan, which just so happens to be the first of its kind in Canada. But first, a few housekeeping notes. Please note that we are being recorded, but only the presenters and panelists are visible on screen. You are not on camera, and everyone is automatically muted. So if your dog is barking or the parcel comes, don't worry about it. You will not be recorded in the background. Today's agenda includes, at the beginning, a 15-minute video of an actual tour of the Providence Heart on Davie, highlighting the Rapid Access Chest Pain Clinic and the STAT Clinic. One note about the video, the quality will depend on your service provider and your internet connection. Don't worry if it gets a bit choppy. We will email everyone a link after the event so that you can watch it or rewatch any spots that you may have missed. After the video, we'll meet with our special guests for a quick discussion before opening the floor to questions and answers, and we will be completed by 5 p.m. tonight. For the Q&A, please submit your questions as they come to mind, especially as you're watching the video. You can type them right into the chat. You don't have to wait for the session. And as you populate, you can also thumbs up other questions that you see that you agree with or would really like answered. Okay, so that's the housekeeping out of the way. Let's get started with an introduction to the doctor who helped turn the vision of a rapid access heart clinic into a reality, Dr. Annie Chu. Dr. Chu is the physician lead at the Chest Pain Clinic and the Providence Heart General Cardiology Clinic, as well as the cardiology lead for the Vascular Medicine Clinic. She also sees patients in the Atrial Fibrillation Clinic, the Cardiac Obstetrics Clinic, and on the wards of St. Paul's Hospital. I think it's very safe to say that Dr. Chu lives and breathes all things heart health here at St. Paul's. We're very fortunate to have her leading the team at the clinic and to have her here to introduce the video that we're about to watch. Hi, Annie. Thanks so much for being here. Over to you.
Thank you, Brooke, for your kind words, and thank you to the Foundation for having me here today. First, I'm deeply grateful to be here on the unceded and ancestral homelands of the Musqueam, Squamish, and Tsleil-Waututh nations. And I'm also very delighted to share with you some of the important work that we're doing here at Providence Heart, which is home of our 2 new rapid access cardiology clinics, but also to introduce you to the dedicated healthcare providers that I work with. Since its inception in November 2020, the Rapid Access Chest Pain Clinic has served as a patient-centered response to providing accelerated, compassionate care to patients experiencing chest pain symptoms. Not only do these patients get faster access to cardiac investigations, expedited care with the cardiologist in a quieter environment, but the clinic also helps to offset the volume in the ER and to lighten the load for our cardiology team at the hospital. As you'll see in the video, this model of care was inspired by a similar model in the United Kingdom, where it provided highly effective and a very quick way to diagnose coronary artery disease, which is hardening of the blood vessels. In addition to that, we've actually further developed an innovative algorithm to help us on this journey while ensuring that our patients continue to receive the care that they need. Of course, as we continue to build out our program and expand our referrals, we have to recognize that none of this would have been possible without the significant interdepartmental collaboration with my talented colleagues, some of whom you'll be meeting shortly, but also the support of our donors as well. But before I give you too many spoilers, let's now take a look at this behind-the-scenes tour of the Rapid Access Chest Pain Clinic.
Hi there, my name is Sean Varani. I'm the head of cardiology here at Providence Healthcare and the physician program director for the Heart Center at St. Paul's Hospital. It's my pleasure today to welcome you to Providence Heart on Davie Street. This is the home of our chest pain clinic and our stat clinic. Both of these innovative programs were conceived of 18 months ago. It was at that time that we began to realize that there was opportunities to improve the care for our patients with chest pain and other cardiovascular problems who present to the emergency room. Like all innovative programs here at St. Paul's Hospital, we work in collaboration with our partners. In this case, it was with the Department of Radiology and the emergency room to come up with interesting and transformative ways of working with patients and their families to really foster and develop a patient-centered model of care. What does that look like? That looks like wrapping care around our patients, making it easy and seamless for them to get care when care is needed, whether that be for chest pain or any other cardiovascular problem. Come with me. I want to show you around and introduce you to a few of my colleagues. The origins of the chest pain clinic, again, started about 18 months ago. And it was at that point that we began to look around and see what were the best centers in the world doing. What was the standard of care for patients presenting to the emergency room with chest pain? That took us to Scotland, and that took us to a group there who was using innovative technologies to help identify coronary artery disease or blockages in the arteries of the heart early on in a patient's disease course, helping to understand whether patients needed treatment urgently or whether that could be done in a more of an ambulatory setting. And part of that is also the acquisition of new equipment, like a high-tech CT scanner. And that's where partnerships with radiology and the foundation, who actually make it happen, came to be. The most impactful thing the chest pain clinic and the stat clinic can do is provide patients and families with reassurance. Patients and families want to be reassured that there's a plan in place for whatever symptoms they have or for whatever disease we ultimately end up uncovering. The chest pain clinic ensures that diagnosis occurs promptly, that there's a plan in place, and a team of individuals that can take care of their questions and their needs, whatever may emerge. The innovative chest pain clinic and stat clinic are now models of care for other jurisdictions within the province. We've been able to spread our reach and meet and see patients that are in other parts of the province where they may not have access to regular cardiology care. Reaching out to emergency rooms, small communities, now with the help of telehealth and virtual health, really allows what we've done here at St. Paul's Hospital to be transformative across the province. We really look forward to expanding the reach, impacting more patients, and really turning the corner on cardiovascular disease in this province.
Hi, my name is Annie Chu. I'm the physician lead for general cardiology at St. Paul's Hospital, as well as the physician lead for the chest pain clinic. Since the start of the chest pain clinic last November, we have seen over 300 patients. What we do is we streamline patients that are lower risk with chest pain to the chest pain clinic, where they will get outpatient rapid access to a cardiologist, instead of them having to wait in the ER to be seen by the on-call cardiologist. In doing so, we decongest the volume in the ER, we allow the on-call cardiology team to focus on the sicker patients, and we also shorten the patient's time and exposure in the ER. At every clinic visit, we talk to the patients and start treatment if they have heart disease, or we reassure them if they don't have heart disease. One of the innovative ways the chest pain clinic has impacted patient care is the development of an evidence-based algorithm where emergency physicians and even cardiologists can use this algorithm to decide on the most appropriate cardiac test for each chest pain scenario. And currently we are integrating this into our hospital electronic medical record system, but it's also available online. The referral process is very simple. We are currently only accepting referrals at this moment from the emergency department, from the urgent care centers, as well as various clinics in the hospital. What happens for a referral is that the emergency physician will use the decision algorithm to decide on the most appropriate test for that patient. And they can actually book the test even before the patient leaves the emergency room. So that way they have an appointment time in hand and they're less likely to be lost to follow up. And the chest pain clinic will then book the patient to be seen by a cardiologist on the same day as their test. I'm extremely thankful for our colleagues in the radiology department, the emergency department, the stress lab, the echo department, and the nuclear medicine department in helping us enhance patient access and care. Through teamwork, they have allowed us to dedicate reserved spots for cardiac tests for these patients so that they can be seen rapidly before they're seen in the chest pain clinic. Otherwise, they would have to endure months and weeks of waiting as an outpatient. I do recall that on Christmas Eve, I was working in the chest pain clinic, and a lady had gone to the emergency department with chest pain that didn't sound cardiac, but because of the algorithm, she had a cardiac CT, and surprisingly, that identified a 70 to 99% blockage in one of her major heart vessels. And so I saw her in the chest pain clinic right after that test, and I was able to start treatment right away. And I'd like to think that she had a much better Christmas as a result of this. The donor funds have been instrumental in helping us provide a clinic space so we can do our ECGs, our Holters, our stress tests for patients, as well as provide a very comfortable environment where we can see our chest pain clinic patients.
Hi, I'm Dr. Ken Kayla. I'm one of the cardiologists at St. Paul's, but I also have the privilege of working in quite a few different areas. Quite a few years ago, we were able to develop the STAT Cardiology Clinic, which provides rapid access to patients that are in the emergency room, and also family physicians in the community that want rapid appointments for patients. There's a big gap between waiting for an appointment with a specialist, being referred from their family physician, and the other option was going to the emergency department. When they come for their appointment, they are able to do it in this setting, which is much quieter than an emergency room. We can have a better and more detailed conversation and finalize the plan because we have the testing that was needed for them already completed. And what can I say about the space? It's an excellent space to have appointments with patients. It's close to the hospital. But it's been separate, which is a nice finding, especially in the time of the pandemic. So we've been able to see quite a few benefits from the institution of the STAT clinic. The emergency doctor's feedback to us is they feel much safer being able to discharge patients with a follow-up plan that they know that the patient's file and the patient's going to be seen by a cardiologist. And so when we saw the evolving pandemic, we were able to quickly switch to virtual care. And that has given us the opportunity to see patients locally and patients that we would not have seen previously. And so we've been able to provide specialty care to patients that previously would have to travel quite significantly for urgent consultations.
Hi, Jonathan Leipzig here. I practice medicine at St. Paul's. My area of interest is cardiac imaging. I'm formerly the head of the department here at St. Paul's, but I've taken on a regional role for Coastal Health, Providence Healthcare. My passion is serving the patients of Providence Healthcare, particularly as it relates to their cardiovascular needs, focusing on understanding risks of heart attacks, using imaging to advance our understanding of that risk, and also using imaging to help plan minimally invasive procedures. So as you can probably see, we're standing in here in front of our dedicated cardiac CT scanner, so-called cardiograph. This has been a purpose-built scanner designed right from the ground up to serve patients with heart conditions and to better understand their nature of their symptoms. This is a source of tremendous pride for me, and I feel very grateful to the foundation and to the donors who've afforded us this opportunity to be the first to use such a scanner in Canada and one of the first in the world. It's disrupted our practice, it's shortened our wait lists, it's improved our diagnostic accuracy, and I think ultimately it's provided greater certainty and comfort to the patients that we serve here every day at St. Paul's Hospital. So this CT scanner, you may sort of wonder as a layperson or even as a physician, how does the CT scanner help improve outcomes for patients with heart disease? Well, even though I love cardiac CT, I always admit that the radiation itself doesn't cure heart disease. What really cures it is working in concert with our clinical cardiology colleagues, with our emergency medicine colleagues, with the nurses and nurse practitioners, and with the patients and the dietitians and all of the ancillary supports that use the information that we get from the cardiac CT to personalize a patient's individual care. So instead of treating a patient based on their risk of having disease, we can actually take a look in a patient with symptoms and we can understand, do they or do they not have coronary artery disease? How extensive is it? How severe is it? And it's with that information that the cardiologist is empowered to make personalized treatment decisions for the individual patient in a fashion that reduces heart attacks over traditional assessment. If you're having symptoms that are more vague or atypical, it really offers us a chance to see patients in a more comfortable environment and really make thoughtful decisions around their care, also decanting and eliminating some of the real pressure that our emergency colleagues are facing with all the complex things they're dealing with, particularly obviously during this COVID pandemic. But one of the things that I realized was that it's kind of like in the old movie Field of Dreams, if you build it, they will come. And we built this program and suddenly we were getting referrals from everywhere. And while this was very exciting for us, what we realized in time was that we were not providing timely care to our patients. Our wait list went from 4 weeks to 6 weeks to 6 months to 8 months. And patients waiting with symptoms of possible coronary artery disease can't wait 8 months. And so through the support of the foundation and the generous donors, we've been able to introduce this dedicated cardiac CT, which is not only operating at a faster speed and providing excellent image quality, by essentially operationally driving efficiency. By only doing cardiac scans, we've been able to realize a significant improvement in our throughput. So we went from doing 14 cardiac CTs a day to doing 24 coronary CT angiograms a day without really a significant increase in our technologist capacity nor in our nursing capacity. Really just solely driven by the efficiencies of having a dedicated cardiac CT. As a result, we've reduced our wait lists back down into the few week time period, which is perfectly safe and reasonable for the indications that we're talking about.
As you can imagine, we're really excited about the new St. Paul's. This is a once-in-a-lifetime opportunity to impact healthcare for British Columbians, and specifically their cardiovascular care. In collaboration with our partners at the Foundation and our colleagues within St. Paul's and Providence Healthcare, we're exploring innovative and transformative opportunities for how we can actually deliver care in a new way. From management to diagnostics, intervention to, most importantly, prevention of cardiovascular disease. We're searching the globe to find those best practices and not being shackled by the current to vision the future. We envision the chest pain clinic will be different in the new St. Paul's. Looking at a new model of how we deliver care, redesigning our healthcare system. With a focus on virtual health and other forms of healthcare technology, we can expand and reach patients all across the province. With a focus on Aboriginal health, as well as really looking at our priority populations, including those who may be marginalized from a social perspective. Chest pain clinic and the stat clinic will be available to all of them through this new model of healthcare delivery. All of this is being made possible through philanthropy and generous donors such as yourself. With support from the Foundation, the hospital, all my colleagues working together, and placing a lens and focus on the patient and the family, we've been able to advance cardiovascular care for our patients. I know that many of you are interested in just that vision and mission. Many of you are interested in advancing research and education, and we've been able to do that. These dollars and this philanthropy has supported improved cardiovascular care through diagnostics, through management intervention, and once again, to support prevention of cardiovascular disease in this province. With New St. Paul's on the horizon and so many innovative programs that we want to be involved with, your ongoing support is going to make that happen. And we look to you, your generosity, and your visions and ideas for the future to build upon that, to drive us to that desired future state. Thank you for joining me on this tour today of the Chest Pain Clinic and the Stat Clinic. I hope you enjoyed it as much as I enjoyed taking you on the tour. Reach out if you have any more questions. I'd be very happy to answer them, as I know any of my colleagues would as well.
Thank you so much for what you do for us, our patients, and for the hospital.
Without you, I wouldn't be sitting here in this wonderful space telling you of our stories of success and our wishes for the future. So, thank you.
That on behalf of all of my colleagues here in the Department of Medical Imaging, that I want to express my most sincere gratitude and appreciation.
Well, thank you so much. It's always amazing to see the passion, and I have to say, we feel so lucky to have these incredible clinicians, physicians working at Providence Healthcare and taking care of patients. It's also incredible to see firsthand how impactful donor funds can be and have been in providing comfort and care to our patients, especially in the midst of this pandemic. You know, one of the things we haven't talked about here is that all of this happened during the season of the pandemic. And, you know, this innovative approach to the cardiac care is truly a testament to the passion that exists within these clinicians, physicians, and at St. Paul's. So thank you for your support. I'm happy to see that we already have a number of excellent questions in the queue. Thank you. Keep them coming. Remember, if you like one or you see one that resonates, hit that click button and vote it up, and then we'll get to those Q&As in a second. Now, before we do, we're going to try something new. It's always fun to try new technology. We're going to do a poll here. So in a second, you're going to see something come up onto your screen, and it's a poll around a question. And we'd like to ask you, our attendees and our donors, this question. There it is. Have you or a loved one ever had unexplained chest pain or shortness of breath? So click on this and say either yes, we went to the emergency, or yes, we went to a primary care, called 811, yes, but we didn't seek medical help. No, I've never had symptoms before, or I don't know. So please click on that and hit the submit button so that we can sort of get a sense. And then also the second question that's in the poll for us today is, how many steps do you get per day? So I have this little watch here that forces me to walk, or encourages me, I should say, to walk at least try and get my 10,000 steps a day. I don't always get there, but I often get there. So that's my answer to that question. So let's go ahead, submit those. So, wow, 43%. Yes, I did have unexplained chest pains and went to the emergency department. 15%. This is an interesting one. I'm sure Dr. Varani will want to talk about this one. Yes, I did have that, but I did not seek medical help. Going down below, you can see how many steps do you get per day? 7,500 to 10,000. Hey, well, I think that's pretty good because I think I'm probably around that category. I'd like to think I'm in the 10,000 plus category, but we also don't have any super marathoners here. Nobody over 15,000. So really interesting results from our poll, and talking now, you know, a little bit more about the people that you're sharing the screen with and sharing this conversation with. Now, I'd like to introduce you formally to the stars of the video. You've already met Dr. Annie Chu, and I'd like to welcome Dr. Sean Varani, Chief of Cardiology at Providence Healthcare and Physician Program Director for the Providence Heart Center at St. Paul's Hospital. Dr. Varani is also the Provincial Medical Director for Cardiac Services BC, past President and Board Chair of the Canadian Heart Failure Society. As you saw in the video, he was instrumental in the development of a chest pain clinic. Thank you so much for being here today, Dr. Varani. We'll hear from you in 1 second. I'd also like to welcome Dr. Ken Kayla. Dr. Kayla is a clinical assistant professor at UBC with dual training in cardiology and critical care medicine. He is the medical lead for the cardiology stat clinic at St. Paul's Hospital and the high acuity unit at Mount St. Joseph's Hospital. Thank you so much for joining us, Dr. Kayla. We're so thankful that you can all be here, and I'd like to start off our discussion by thanking you for some of the work you've already done to make Providence Heart a success. I know we have some audience questions already, but why don't I kick things off with a few questions? The first one is going to go to you, Dr. Chu. What would you say are the key physical and lifestyle factors to maintaining good cardiac health?
Wow, I could probably spend a whole day talking about this, but I'll keep it brief. As cardiologists, we're very good at treating a heart attack after it's happened and there's already some heart damage, but we need your help in preventing these heart attacks from happening in the first place. And the key to that is lifestyle. And that all starts with a very good diet. And as cardiologists, we recommend the Mediterranean diet. You can Google recipes online. Also for patients with hypertension or high blood pressure, we like the DASH diet as well. Other lifestyle things, common sense, some of you might not want to hear this, but exercise, regular exercise is definitely very important. And so we recommend something active every day, and we just did the step count poll as well. So a few people could probably increase their number of steps per day. So we would recommend something active 30 to 60 minutes almost daily if possible. There are other common sense stuff as well, not smoking, which we should all know about, and drinking alcohol in moderation. Some people might ask me what drinking alcohol in moderation actually means. And so I would say for a woman, 1 to 2 units of alcohol per day. For a man, up to 2 units of alcohol per day. And if you're a weekly type of person, that would be about 9 alcoholic units per week for a woman and about 14 alcoholic units per week for a man. The lower, the better. And that sort of relates to waistline as well, which is also important. And so for a man, we would ask that their waistline be less than 40 inches. That's the ideal. Well below that would be better. And then for a woman, a waistline below 35 inches. There are different readings or different values for different ethnicities. And some people might also say, well, that's fine because my tent size is 35, I'm okay. But it's actually the part that's above the waistline. So it's not the belt, it's the part that hangs over the belt. That's what you want to keep below 40 inches. So that's important to remember. And then the last thing is maintaining good mental health. So whether that's treating depression or anxiety or managing stress, all that is very important. So those are the lifestyle things that people can do or that everyone can do. And then in addition to that, we have three major cardiac risk factors, and your family doctor or yourself or your other doctors can help you manage those or prevent those from happening. And so those are diabetes, high blood pressure, and high cholesterol. So those are the major things to do, lifestyle-wise and also cardiac risk factor-wise. I'll stop there before I take over the whole webinar.
Well, just one quick follow-up, if you will. Have you noticed, Dr. Chu, changes over the pandemic, right? Like, we've been in the pandemic now since March of last year. It's been more than a year. I certainly, for myself and others, feel like, you know, my heart health has definitely declined to a certain extent. Is that just an individual thing, or have some people really gotten out there and gotten healthy during this time?
Right. So I think one of the other poll questions that we could have asked is, during the pandemic, which one of these three things happened? Did you need to get extra pants or bigger pants? Did you support the alcohol industry, or did you actually get fitter and better? So I think most people would have gone one of those three ways. I would say, unfortunately, just talking to my patients, most patients have needed to buy an extra size and supported the alcoholic industry a little bit more. So I think a lot during the pandemic, there have been some not as great behaviors. So now it's your chance to really reverse that, especially with the nicer weather outside.
Now is the time to invest in exercise, for sure. Okay.
There you go. Yes.
So this question's for Dr. Kayla. What's your most impactful memory or patient story from doing the type of work that you do?
Well, thanks. Great question. I think quite a few come to mind, and they usually come from the intersection of, you know, we have so much expertise at St. Paul's, and recently, and we've been able to marry that with, you know, the resources and organization with these clinics. So, you know, even just in the past week, 2 urgent patients were referred. They came down to visit a family member, and because their health was failing, and usually that times of stress can bring out conditions or things that they've had before. And so 2 family members had sudden cardiac issues, and we saw them on the same day. It was minimally kind of effective to their, had a minimal effect on their schedule, and they were able to spend the most amount of time with the person that they came down for. So I think those kind of stories of kind of rapid and complete care is things that really touch me and make me feel good about what we're able to do.
Yeah, absolutely. Those are great patient stories and a great testament to the work that you all do and the support that we've received. You know, Dr. Varani, what do you see as the need? What do you see as the need in order to work better, to support patients better? And is there a space where donors could help in some of these needs that you see?
So thanks for the question, Brooke. You know, I wear a number of different hats. So, you know, my clinical hat, many of you will know, I work with patients who have heart failure and who need heart transplants. And St. Paul's is the provincial center for advanced heart failure care and for cardiac transplantation. And so I feel very passionate when I put on my clinical hat about creating capacity in a system of care for patients across the province with this. So heart failure is the leading or second leading cause of hospitalization in Canada. It sort of goes back and forth between COPD. And it costs the healthcare system about $2.8 billion per year and is a major source of morbidity and mortality. So people dying and not feeling well or having poor quality of life. And in British Columbia, we are able to care for about 5% of the patients who have heart failure through established heart failure clinics and programs. So that is a huge number of patients that don't have resource or access to heart failure care that can sometimes lead at its end stages to heart transplants and mechanical hearts and all kinds of things you've heard St. Paul's do amazing things about. So in a very roundabout way of answering your question, we have, as the provincial center, all kinds of need for technology, for infrastructure, for programs and care processes that can support patients, can support the clinicians to reach patients all over the province. You heard about some of those things, virtual healthcare and telehealth care in the video. You heard Dr. Kayla talking about the ability to bring a patient down and wrap care around them and get everything that needs to be done for them in one go. And what we really need in the heart failure space is that capacity. So those tools that can support heart failure and sort of pre-transplant to transplant care for our patients are desperately needed, and really is part of, really much aligned with what we want to do for the New St. Paul's, very much aligned with the provincial mandate we've been given, and something that we feel passionate about in terms of improving the lives of patients in British Columbia.
Yeah, and that leads to that question that's out there around the New St. Paul's. And this is really for each of you, and perhaps I'll start with you, Dr. Varani, and then pass it to your colleagues. Of course, we at the foundation have been talking a lot about the New St. Paul's and working in sessions to vision what that hospital looks like, working with donors to raise significant funds in order to see it start to come out of the ground. And we had our start of construction celebration back in March, which was so exciting. And I think so many people were hesitant to celebrate because they couldn't believe it was actually happening. And so it's exciting to be here now with the team that you have, the patient cohorts that you see, the opportunities that are before us, and that provincial heart center designation. How do you see the New St. Paul's really changing as you will? You talked about a provincial system. How do you see the New St. Paul's speaking to that and fitting into that change of care for patients province-wide?
So I think it's a lot of listening, and it's a lot of talking to all of our partners across the province, talking to all of our patient populations, talking to our Indigenous communities, talking to my colleagues. I think what the opportunity. Use the word opportunity. It's exciting to sort of think about what the future will look like and to create an innovative model. In some cases, the things that we're talking about may not have even been invented yet. Artificial heart pumps that haven't been invented yet, and yet we need to create a system for the future. So that's a tremendous opportunity. And so listening to all of these groups, listening to what their needs are, and then beginning to sort of, I said in the video, is not being shackled by the present to vision the future, to really look at what are the best ways of delivering care, and then working backwards. Well, what do we need to put in place for that? Looking at that end point and then working backwards, as opposed to saying, well, this is how we do it now. How do we tweak how we do it now to make it better for the future? Just throw all of that away. Start with this tremendous vision, which is like shoot for the stars, what you think the best thing for your patient is, and now let's work backwards. And so for me, New St. Paul's it's bricks and mortar, but it's so much more than that. It's about a new way of delivering care, of which the hospital, bricks and mortar, is going to be a key component, but a component. It's more than just the building. It's about an innovative, transformative way of getting care to patients in British Columbia, and specifically, from my perspective, the best cardiac care to the patients in British Columbia.
Dr. Kayla, any thoughts?
I think one main thing is that's why we're so pleased to have Sean as our leader. And I think, part of, there's been bumps in the road this pandemic. We've learned so much of how we want to treat patients in the future. So I think, I couldn't echo what Dr. Varani has said more, and so proud to have him lead us as part of this development.
Dr. Chu, any thoughts?
Well, one thing that I would add, I think Sean already gave such an eloquent answer. There's no topping that. But one thing that I would add is that I think what's often forgotten is the patient's journey. So the patient experience, they're so overwhelmed when they come into a hospital. They've got all these conditions. They don't know what's going on. They've got these symptoms. They don't have any answers. And I think the patient journey is the most important. So making that patient journey as seamless or as stress-free as possible is the best. And in our current system, we have a lot of siloed off clinics. So a patient might see the diabetes clinic and then the cardiology clinic and then the lipid clinic. But if we can have an interdisciplinary space where patients can be seen in an interdisciplinary fashion, I think that would really improve the patient journey. And that's one of the goals of the New St. Paul's as well. So hopefully that'll really impact the patient care that way as well.
Yeah, that's exciting to hear. I think we all have personal stories. I know my mom had atrial fib, but she also had heart failure and suffered from both. And so, you know, navigating those things as we get older, and as health, you know, can also deteriorate. You know, having that patient-centric focus is so good to hear. Okay, why don't we turn to some questions here? We've got a bunch of questions, and I'm just going to open this up. So if I look like I'm reading or stumbling a bit as I'm pulling these up to take a look. Okay, number one question, voted at the highest. There are different symptoms for men and women. What is the most telling sign for women that they are having a heart issue? Why don't we start with Dr. Chu on that?
Yeah, they're both going to make me answer this one. So I do have an interest in women and heart disease. And we know that women, we don't follow the rules, so we don't have to come into hospital with the typical textbook symptoms of, you know, crushing chest pain when you're exercising. So women do present differently, but the majority of women still present with chest pain. So for patients with blocked arteries or hardening of the arteries or a heart attack, the main symptom is still chest pain about 80% of the time. But women may have atypical symptoms. So atypical symptoms meaning they could just have stomach pain, or they could have shortness of breath, or they could have back pain or jaw pain. And so they're more likely to have these non-chest pain presentations more so than men. So those are typically the things that you can watch for. Now, most of the time, if it's a blocked artery, then it's on exertion, or you got the symptom while you were exerting yourself. And that's because on exertion, you need more blood flow. And if you're not getting it, then it hurts. It's uncomfortable. So exertional chest pain or exertional jaw pain, epigastric pain, those are the symptoms one can look for. And then once you stop walking or once you rest, the pain relieves. That's also a sign that it's maybe the heart, it's maybe the blocked arteries of the heart that's causing your symptom.
Okay, great answer. And really interesting to hear that those different symptoms can present and represent, a heart issue that you may not think about. Next question: can our family physician refer us to the clinic directly?
Okay, so I think I'll answer this for the chest pain clinic, and then Dr. Kayla can answer for the stat clinic. So currently, we're only accepting referrals for the chest pain clinic through the emergency room and the urgent care centers. But our plan, once we start recruiting more people to man the clinic, we'll be able to expand to the community. And so at that point, we'll let the family doctors know that they can start referring. So it's not for maybe a few more months, but it's coming. And then Dr. Kayla can talk about the stat clinic.
Yeah, we're in a very similar stage for the stat clinic that we've tried to offload the emergency rooms and other like urgent clinics. What we will do is, if we are seeing patients and we don't think they can see them in a timely manner that they need, sometimes our referrals we will put into the stat clinic, but we're really hoping with ongoing expansion of our general cardiology team that we can take it the next step and open this very widely.
Okay, great. Well, the next question is not a question, it's simply a compliment. All the doctors look like professional actors. Well done. Okay, well, we're going to have to start taking our cues from the cardiology department in terms of shooting our donor videos for sure. Okay, next question from Renee. What does the echocardiography machine do, and how important is it?
I think I can try that one. So it's called an echocardiogram or an echocardiography machine. The test itself is called the result of it is called an echocardiogram. It's basically an ultrasound of the heart. So I think many of you may be familiar with the type of ultrasound a pregnant woman has of her belly, and looking at the baby. An echocardiogram is essentially the same thing, but looking at the heart. And the machine allows us in a very non-invasive way to look at the structures of the heart, to see the walls of the heart, how the walls are functioning, how they're pumping. It allows us to calculate exactly how much the heart is pumping on a scale of 0 to 60, 60 being normal. It's not 0 to 100, 0 to 60, 60 being normal, and 0 being obviously very, very weak heart. It allows us to look at the valves of the heart and other structures and see how the blood flows through the heart. Is it moving forward, or are there times where the blood is swishing back and forth? So it gives us a lot of really important information on the heart and its structure and its function. And in many ways, it's kind of like the X-ray of the heart. It's really one of those fundamental foundational tests that we need, whether you're talking about patients who have blockages in the arteries of the heart, whether you're talking about people who have valve problems, who have heart failure, atrial fibrillation. Across all of these cardiology diagnoses and disciplines, the echo is really our foundational test. And so it's a very useful and important tool that we use in our practice.
Great, thank you, Sean. And next question, is there a way to differentiate between cardiac chest pain and heartburn from indigestion? For those who are not certain what's going on, how can you differentiate those things?
So there have been some cardiologists who've had abdominal pain and thought it was just acid reflux, but without actually having with having a heart attack. So this is a cardiologist that has made that mistake. So the short answer is we really don't know. It's really hard to tell. There are some clues that you can use. So if the pain is usually after eating, and especially with certain foods, spicy foods, citrusy foods, and then you take some Tums and it feels better, usually that's acid reflux, that's heartburn. But like I alluded to earlier, if it's an exertional discomfort and then you sit down and it goes away, it's probably more of a blocked artery type of pain. So there are certain clues, but it's still not the most exact science, and it's sometimes very hard for a layperson and even for a cardiologist to differentiate between the two.
Yeah, so some good anecdotal things to sort of test there and try for sure. But probably the best idea is to call 811 or family clinic or head to the Emerge. Okay, I think this is probably for you, Sean. What's your timeline for expansion of services? Will there be more clinics modeled on this throughout the province?
So I hope so. I mean, I think that also has to be coupled with I don't know. We at Providence Healthcare certainly have control over our jurisdiction, if you will. And so we've established a chest pain clinic and a stat clinic to support patients with a variety of cardiac diagnoses. And maybe Ken will get into what the difference is, because I know those are questions in the chat. But where other health authorities are concerned, we don't have control over saying we're going to start up a clinic in Burnaby, for example. That would fall under the auspice of Fraser Health Authority, or in Prince George, because that would fall under Northern Health Authority. So we are limited in terms of our purview. But what we can do is reach into those health authorities where there isn't a resource. Certainly if there is a stat clinic in New Westminster and Royal Columbian is happy to support that and provide care for their patients, that is really the ideal situation. But there are an equal number of spots where that doesn't exist and where there's a gap, and we would want to partner with those health authorities and say, hey, we will support your patients. And so that really, as Annie referred to, is the next step of things, is reaching out to the family doctors within the community, not just in Vancouver Coastal Health and Providence Healthcare, but across the province, and say, if you don't have this resource available to you, then we are happy to step in. And I think that's what the role of a provincial heart center is, right? If the resources don't exist locally, then we are there to be that safety net provider. If you don't have access or capacity, we will do it, and we will make sure that every patient in the province has a resource that they can count on. We don't want to see people fall through the gaps.
It's an interesting question and an interesting challenge, I think, especially for you at the Heart Center. Every week, I see the bus from Northern Health parked out front with patients traveling back and forth because of the expertise that's at St. Paul's that simply they don't have access to in other locales across the northern part of the country, or the province rather. So the more we can use that new St. Paul's model and get those clinics out there, I think what you're talking about, Dr. Brandy, is part of that future. Okay, important question. How much is a unit of alcohol? I'm used to thinking of it in shots. So how many is that right? Do I talk about shots or do I talk about servings? What's a unit?
It depends on the beverage. So a unit of wine is 5 ounces. So you can't take the biggest glass that you possibly can and count that as one glass. So it's 5 units. A unit of beer is just a can of beer. So it's the bigger one, the 350 mils. And a unit of hard liquor is an ounce. So vodka and tequila, that's 1 ounce. And also you can't save up, all 14 units and have it all in one go either. So it has to be distributed over the course of the week.
Well, I think that's such good counsel in the time of the pandemic, and especially as we come out of it and cases come down, and we start thinking about summertime and going back to the patios. For the first time in a year, I met with a physician, a colleague, today over lunch, and it was the first time that we were outside on the patio, but it's the first time we'd done something like that since 2019. Okay, what types of patients are seen in the STAT clinic? How is it decided that someone gets referred to the STAT clinic versus the chest pain clinic? So I think Dr. Kayla, this is for you.
Yeah, so I think the STAT clinic has started to kind of cover the wide range of cardiac conditions. So the chest pain clinic is more tied to the CT scanner looking for those blockages, whereas other heart conditions can come up. People can faint, they can feel their heart racing, they could just be short of breath, and it doesn't seem that it's clearly coming from a blockage. Someone's worried about their valve function of their hearts. So it's to cover kind of everything else that needs urgent attention. And so often we were finding that people were going to the emergency room or getting the answer that, oh, it's not a heart attack, but they're still having symptoms. And that's what we're really trying to address with the STAT clinic.
And that sort of answers this next question as well, in the difference between the STAT clinic and the rapid access chest pain clinic. Anything to add, Dr. Chu?
No, I think you've explained it really well. So one is chest pain, one is everything else. That's cardiac, that's not chest pain.
Exactly. So we have an attendee here who's a registered dietitian and works with patients, clients with cardiovascular risks. The question is, how can they connect with the team to promote the program and to refer to either the group, an inline program, or for those who still want sort of one-on-one support?
So maybe that's something that I can take offline with the attendee, Brooke, and we can figure out what the best linkages are. And we have resources within the Heart Center, so it may be that we can use the expertise of this attendee to supplement that, or to learn from it, or develop some kind of relationship. So we'll take that offline and explore it a little bit more.
Excellent, thanks, Sean. What type of care do patients get after being diagnosed with heart disease? Do they get medication? Do they get surgery? What kind of care?
So that depends on the heart condition itself. So if it's a blocked artery, it depends on the severity of the location, the symptoms. If it was a heart attack, you would get a stent. If it's a heart attack because of multiple blocked arteries, instead of putting in multiple stents, then you would get that bypass surgery. If it's a valve problem, then we follow the valve until it gets to a point where we think the benefit of replacing that valve would exceed the risk of going through surgery. If it's your heart being weak, that's Dr. Varani's his clinic and his heart failure team, and that would be using medications to strengthen the heart as much as possible. Finding out the reason why the heart is weak in the first place. If it's a blocked artery, then we'll open up those arteries. If it's a valve that's problem, we'll fix the valve. So we find out the reason for the weak heart in the first place. We use medications to strengthen the heart, and then we consider other options if we can't improve the heart function. Likewise, if it's a rhythm problem, so it's a fast rhythm or a slow rhythm. A fast rhythm we can treat with medication. A slow rhythm we might just put in a pacemaker. So it depends on the condition. So
there's a real variety of options there, depending on the case. depending on the patient.
Mhm.
Probably for you, Dr. Varani, what are the current heart failure treatment gaps? And what are the most important program strategies delivering the most impact to these gaps?
So thanks for the question, Tyler. I think I kind of spoke a little bit to it. I think at the end of the day, access to care remains the main priority. We had the opportunity to partner recently with the Heart and Stroke Foundation of Canada to do a really broad sort of scan of Canada and talk to all of the major, partners and players in the heart failure world. Including, most importantly, patients. And what comes out over and over again is timely access to heart failure care. Followed closely behind is getting appropriate treatment, guideline-directed medical therapy. So whatever the experts think is the best combination of treatment for heart failure is access to that. And then the third thing is really, as Annie referred to, it's transitioning patients. So across their entire journey, from the time where they're diagnosed through to being seen in a clinic or their primary care physician's office or a hospitalization. It's just this ensuring that it's seamless all the way along. We're very good in the healthcare system at episodes of care. So you go in to see this person, or you go in to see that person, or you have a surgery, etc. And the in-betweens tend to not be so robust. And so I'll bring this back to the new St. Paul's, right? And the comments that Annie made before is what we really want to see is a consistent, supported, thoughtful patient journey where there are no gaps. Where we have anticipated those and where we have created a framework where the patient is supported throughout, regardless of where they live. And we hear about this a lot in heart failure because there are so many transition points in the patient's journey. And every one of those points is an opportunity to drop the ball. So I would say access, medical therapy, and transition are really the key points for heart failure patients, as I think they are, frankly, for all patients within the healthcare system.
For sure. So just quickly, what's the referral time from ER to clinic?
Well, our mandate is that we will see patients within 48 hours after they've been referred to the clinic. So they get their cardiac test and see a cardiologist within 48 hours.
Amazing. Here we are, 4:59. And thank you for that last question about how proud each of them is about setting this clinic up. I'm going to suggest that we close off our session here. So I want to say thank you for all the time, and I'm so grateful for you, Dr. Chu, and you, Dr. Kayla, and also for you, Dr. Sean Varani. Sean, you and I have worked together for a few years now, and it's just such a pleasure to always speak with you and hear your vision for the Provincial Heart Center, not only now, but in that future. We've got a few more years before we open the doors of the new St. Paul's, and I know with your expertise and leadership, but also the support of the donors, we're going to build that program to really fill that new hospital to excellence. So, if you are interested in supporting cardiac care, you can donate now by visiting the link posted in the chat and on screen. And if you have questions, please feel free to contact my colleague, Taya Beck at St. Paul's Foundation. You can find her information here on the screen as well, just below. I hope that you'll leave feeling inspired, as I am, by the work that we're doing now, and also excited about what is to come in the very near future at the new St. Paul's Hospital at the Jim Pattison Medical Center. Thank you so much, everyone, and enjoy a wonderful evening. Good night.